Hi everybody, welcome to this video. It's more of a hodgepodge type of video in terms of what I'll be covering today, and it's all psychiatry related. So in terms of what I've been covering today, I'm going to be covering material that is based off of T. Zanke, and there's just random bullet points. And I hope that this helps you understand the material a little bit better. So the first bullet point that we're going to talk about today is typical antipsychotics that are associated with purple, gray, metallic rashes over the sun-exposed areas and jaundice is chlorpromazine. So when you think about chlorpromazine, I want you to think about, if they bring up a question on test day, I want you to think about chlorpromazine, and I want you to think about it being associated with jaundice and a rash. So let me just pull something up here really quickly. So chlorpromazine, that is associated with a purple gray metallic rash, as well as jaundice. Okay, and then next bullet point here is the caudate nucleus atrophy is associated with Huntington's disease on CT and MRI. So you can see here in this image here that that's associated with CT, MRI, and Huntington's disease. It's associated with caudate nucleus atrophy. So just memorize that fact. You have to know that. The next thing that we'll talk about is atypical antipsychotic. That's associated with increased risk of EPS and hyperprolactinemia, and that's going to be risperidone. So if you see in a question about antipsychotics, and it's about second generation antipsychotics, and it's about which one has the increased risk of EPS and hyperprolactinemia, it's going to be risperidone. So let's go through this chart of the second generation antipsychotics. So we have aripiprazole, olanzapine, risperidone, ziprasidone, clozapine, and quetiapine. And then we want to look at three separate side effects that can happen. So we can look at weight gain or metabolic syndrome, extrapyramidal side effects, and then prolonged QTC. So when we look at aripiprazole, all three are low. So it's a nice medication. All three are low. When we look at olanzapine, weight gain is very high. So that's important to note there. So weight gain is going to be very high. Other than that, though, the rest of them are low. So low and low. And then for risperidone, unfortunately, this medication, just keep in mind that everything is going to be very high. So high, or not very high, but it's going to be high, high, and high. And then for ziprasidone, you're going to see a prolonged QTC, but you're not going to see extrapyramidal side effects, and you're not going to see as many changes in terms of weight. And then clozapine, again, you're going to see low chances of extrapyramidal symptoms and then low prolonged QTC. But then the chance of metabolic syndrome is very high. So remember, clozapine and olanzapine are going to be the medications that are going to cause increased amounts of weight gain. And then lastly, we have quetiapine. It also causes weight gain, but it has a low chance of causing extrapyramidal side effects as well as prolonged QTC. Next bullet point that I want to bring up is the antipsychotic of choice in patients for anorexia after, keyword after, CBT and nutritional rehabilitation have failed is going to be olanzapine. So just remember that, olanzapine if CBT and nutritional rehab fail in an anorexic patient. Next point, SNRI is going to be avoided in hypertensive patients. The SNRI that you need to avoid is going to be venlafaxine. So remember that venlafaxine is going to be avoided. So avoid venlafaxine. Patient is hypertensive, their blood pressure is up 140/90 or greater. You do not want to give this medication because it can increase the diastolic blood pressure. The next medication that we're going to talk about is Mertazapine. So remember, Mertazapine is the treatment of choice. Mertazapine is the treatment of choice in a depressed patient with poor appetite, weight loss, or insomnia. as it increases appetite, weight gain, and sedation. So I know that you may get confused and think, oh, well, what about trazodone? Well, trazodone can help with insomnia, but it's not going to help with the weight gain. So mertazapine is that triple punch where it can help with appetite, weight gain, and sedation. So remember, if you have a patient with appetite, poor appetite, weight loss, and insomnia, mertazapine is your go-to medication in a depressed patient. And the next bullet point here is about somatic symptom disorder. So remember that somatic symptom disorder is going to be associated with a person who has a preoccupation with one or more physical symptoms that are unexplained by anything else. The key here, very high yield, establish single physician as the provider with regular appointments, and avoid additional testing and therapies, and definitely try and avoid hospitalization for these patients. Next bullet point that I want to bring up is fluphenazine, and this is an antipsychotic that causes high-yield hypothermia and disrupting thermoregulation and the body's shivering mechanism. So in these patients, if they're on fluphenazine for whatever reason, I've never seen a patient on this medication, but if you see a patient on this medication, make sure to tell them to avoid prolonged exposure to extreme temperatures, and this is all due to the effect of the regulation at the level of the hypothalamus. Trichotillomania, remember that these patients can get small bowel obstructions secondary to bezoars because they're eating their hair. Next, clozapine is the atypical antipsychotic that is least likely to cause tardive dyskinesia. And remember, management of tardive dyskinesia. It includes discontinuation of the causative agent, switch to a second generation antipsychotic such as quetiapine or clozapine if you have to use an antipsychotic, and then treat with felbenzine. Next point, first line treatment of adjustment disorder is, remember this, psychodynamic psychotherapy. So psychodynamic psychotherapy is like never the answer usually, but it is the answer for adjustment disorder. Or you can do brief cognitive psychotherapy. And remember, AD must start within 3 months of onset of the stressor, and it has to be resolved within 6 months later. And it causes pretty significant functional impairment. Next thing that we're going to go through are going to be the immature and mature defenses or defense mechanisms. And so these are very, very frustrating to go through, and they're kind of annoying. So I would just recommend going through it once or twice, and then I think that on test day it becomes very like second nature. So first ones that we have are the immature ones. And so first one is going to be acting out. So acting out, expressing unacceptable feelings through actions. The next one is denial, behaving as if an aspect of reality does not exist. So a person is in denial when they think something is real when it's not real. Displacement, this is like the classic example of the resident yelling at the medical student when he gets yelled at by somebody else. So this is transferring feelings to a more acceptable object. Intellectualization, using intellect to avoid uncomfortable feelings. I think a lot of doctors tend to do that. Passive aggression, this is pretty self-explanatory. Avoiding conflict by expressing hostility covertly. Projection, attributing one's feelings to others. So, for example, people in a romantic relationship, maybe one person thinks that the other person is cheating because that person is attracted to other people. Next one, rationalization, justifying behavior to avoid difficult truths. Reaction formation, responding to a manner in opposite of one's actual feelings. So that's when the stepmom acts really nice to the stepkid but really doesn't like the stepkid at all. Regression, reverting to an earlier stage of development. Splitting, seeing all others as good or bad, self-explanatory. The mature ones that we have here are going to be sublimation. So this is channeling impulses into socially acceptable behaviors. So this is like the aggression one where like a person with aggression channels their behaviors into sports. The next one is suppression, putting unwanted feelings aside to cope with reality. And then a couple more high yield points here that we'll go over in this presentation, because I know it's getting to 10 minutes and then it gets kind of boring after that. So part of the brain that is affected in Alzheimer's is going to be the nucleus basalis of Maynard. So when you think about Alzheimer's, remember nucleus basalis of Maynard. And you can watch my video on neurotransmitters in different disorders to go into more detail on that. Remember here, diphenhydramine is an H1 receptor antagonist, and it can be used for management of acute dystonia. So acute dystonia is going to be sudden, sustained contraction of the neck, mouth, tongue, and eye muscles, and these are your extrapyramidal symptoms, very high yield. Benztropine is going to be one medication, diphenhydramine is going to be another medication. Anesthesia, subjective restlessness, you can give a beta blocker such as propranolol, benzodiazepine such as lorazepam or benztropine. So you'll notice that benztropine is a great medication because it covers most of these. Parkinsonism, gradual onset tremor, rigidity, bradykinesia. You can give amantadine or a benztropine. And then lastly, we have tardive dyskinesia. And this is where you have dyskinesia of the mouth, face, trunk, or extremities, where they have like strange movements or they have like lip smacking, things like that. Usually happens after 6 months of therapy, so you have to watch out for this after you start a patient on antipsychotics. Treatment is going to be discontinuing the antipsychotic, and then you can start benazine as well. I hope that helps. So that's a quick high-level review of some psychiatric facts that you have to know for Step 2 CK. Thank you for watching.